Assalamu alaikum, my dear candidates. How are you all? Hoping all are well. First of all, today, starting my session, I want to discuss few important question. As I observed, there is a Eid holiday, but my question practice always there, and there's some question personally or some confusion. Some are solving recall, some are facing problem. Though my session and course chapter wise, but I always solve those confusing question and recall. Cause recall means what? I'm a candidate. I just tell this sort of question I face, but it doesn't mean that it is complete recall. But I have to make sure this type of scenario I have to correct in my exam. Okay, so it could be the any factor related question. It could be the non-specific type of TB question, but I have to make sure if it is TB question but not symptomatic, is it symptomatic or not, but how I will mark the question in my exam, whatever the recall it is. In Allah edited file, I had given the access to all of my candidates. My strong recommendation for my DHA, HAD and MOS candidates, mainly DHA and MOS candidates, solve it 3 times. This also a collection of recall, but why 3 times? Cause same option and scenario related question you will find out more than 60%. Cause why? Candidates ask me personally, I forget the name and scenario. They were like the femur spectral, like something like the child. Base definitive initially. Base definitive always exploration initially always keyword if it is baby. Still I didn't discuss regarding orthopedic questions, surgery related complication, trauma, many things. Just started my session, I started with cardiology. But Dr. Kupsia maybe or some question were regarding the hemolytic transfusion reaction and non-hemolytic transfusion reaction. Non-hemolytic transfusion reaction means what? After giving the transfusion, there is no blood come through any site of your body. It means hemolysis ongoing, RBC are destroying in your blood picture. When you see the CBC count, hemoglobin are dropping, but there is no, I will discuss all the things in the hematology part, but there is no bleeding comes throughout the any site of body. It's a non-hemolytic transfusion reaction. Hemolytic transfusion reaction, even if you give 1 or 2 unit blood, but hemolysis is Uzi. It's my exam question on the bleeding point from the cannula. It's a hemolytic transfusion reaction. Question recall was, as far I remember from my group, thrombocytopenia. How, even if you are not doctor, if you think how it could be thrombocytopenia, my dear candidates. First of all, there is no platelet picture in my scenario. They must give you ITP picture, platelet lowering down. No hemolysis like that way. ITP after blood transfusion, this type of scenario still they didn't give. ITP after blood transfusion. Blood transfusion reaction either hemolytic, neither non-hemolytic. ITP, TTP, this question pattern will be just different. All will be discussed in the hematology part. Another candidates were discussing regarding the question yesterday mock maybe.
Thank you, ma'am.
Yeah, okay. Thank you, dear. Another question regarding the, yeah, I now remember the, my dear candidates, endocrine related question. Always remember, thyroid is a status. Whatever is hypothyroid or hypothyroid, as I am practicing my cardiology, whatever status, palpitation, cholinterference, hyperthyroidism, whatever the status, make sure TSS value because they didn't give any clue. The sudden level of hypertension, tachycardia, patient asymptomatic. It was just said, ma'am, I was feeling cold intolerance. But she is not a diagnosed case. You have to make diagnosis. Now patient come to your hospital or admitted due to gallop rhythm, tachypnea, tachycardia. What happened? Either ventricular dysfunction, neither arrhythmia ongoing. Why? Due to thyroid imbalance. It could be hyperthyroidism. It could be hypothyroidism. It doesn't mean that now patient develop thyrotoxicosis. No, I have to make sure thyroid status. Because if we don't know what is ongoing, if we see the ECG, sinus tachycardia ongoing, if we do the echo, there is no abnormality, ejection fraction okay, cardiac function echo all right, but BP high. Why? It could be man one. Man one means what? Multiple endocrine neoplasia. Multiple endocrine neoplasia means what? It could be pheochromocytoma, it could be hypothyroidism, it could be hypothyroidism, addition, lots of things. But you have to make sure you have to save physician. Even after passing DHA, you have to make sure you are the overconfident in Viva. Because they ask in practice, there will be the Pakistani Viva examiner, there's a lots of examiner there, outside examiner, they'll ask many questions, whatever the status you are. So, a patient you are emergency doctor, they are asking this type of question, correlation, you have to know, yes, if even I don't know the thyroid status, I have to make sure, is it hypothyroidism or hyperthyroidism? I hope all clear. I am starting my cardiology session. If any question still I was asking but didn't discuss, can ask me anyone from the recall or any question facing difficulty. Anyone? Okay. From the first of starting my session, and to make sure the confusing question they are facing difficulty, now I want to start the session. If anyone have any question, they can ask me. Can you mute the mic, my dear candidates? Can you mute the mic? So today my cardiology session will be the third session, and I'll complete maximum cover as already 2 sessions. I cover ECG and high topisticity, the myocardial infarction, atrial fibrillation. Kindly mute. It will be nice to mute. So already I discussed again the Chadfa score, warfarin, DUAC, NUAC. I also discussed, and the management value. Very important Chadfa score. You have to know how to do it. I already discussed. So pulmonary edema question. My DHA heart candidates and from and MOH candidates, just remember pulmonary edema question, they like very much X-ray. Pulmonary edema, curly line, expansion of the interstitial space by fluid. They give this picture. My candidates remember this curly line at the picture. And the presentation. Pulmonary edema could be, it is the complication of myocardial infarction or any of the cause behind it. We have to catch it. What are the cause? It could be the due to congestive heart failure, due to the left ventricular dysfunction, either MI, either drug related or any stress related, or any cardiotoxicity, cardiomyopathy, or any cardiomyopathy idiopathic cause, any valvular or non-valvular cause. So it's not my headache. My headache pictures they give, orthopnea, crepitation, auscultation, tachycardia, dyspnea, saturation will be dropping. These are the pictures we will find out in my scenario. Initially, whatever the shortness of breath, tachypnea patient come to my hospital or GP clinic, we have to do chest X-ray to see the carelessness. There is a fluid expansion of the chest X-ray or not. I have to make sure echocardiography to identify is there any valvular disorder or what about the regional valve motion, ROMA. What is ROMA? After AMI, valve motion disabled means what? After anterior AMI, anterior wall will be weakened. There is ischemia. Inferior wall will be the weakened after inferior AMI, so ROMA. We have to make sure by echocardiography, papillary muscle dysfunction after having AMI. So commonly we find out acute mitral regurgitation. Initially, I always emphasize for my candidates, passing is very easy in the exam. You have to make sure what they are asking. Initially, best initial, best definitive, or definitive. My dear candidates, it is just from today or from practice, just make sure it is. Even incomplete scenario you are finding or your friends are giving you feedback, I was facing this type of question. But make sure you know very well what is the initial enactment, what is the initial management, what is the initial investigation. Okay, enough. If you mark it initially, you say, ma'am, congestive heart failure, why I'll do X-ray? Yes. Tachypnea, tachycardia, whatever it could be the type 2 respiratory failure, type 1 respiratory failure. It could be the hypoxic cause. So we have to make sure it is due to the fluid expansion of the lungs, pulmonary edema. I already discussed a question from the pulmonary edema and the heart failure. So management MONA, I already discussed in the AMI related question. Furosemide, Lasix. A patient come to the hospital in emergency, severe breathless. You have to make sure decrease pulmonary edema by IV Lasix. Initially management IV Lasix. So give furosemide, IV form. This morphine actually we give always in failure patient to decrease the anxiety, stress, to vasodilation, but it is not exam question. Pulmonary edema, pulmonary embolism. This type of question, in edema question, they will not give commonly pain, but embolism, it will be the sudden onset, it will be the painful, and patient all will be the hemodynamically instability. So for pulmonary embolism, we have to do confirmatory CT pulmonary angiography. Recently exam question was initially what we will do? D-dimer, CTPA, VQ scan. When we will do VQ scan? If patient pregnant, because CTP will not be safe for the pregnancy. CTP always confirmative, but best definitive if in your option there is a conventional, you have to mark conventional. So just for discussion, there is a many candidates here and I want to discuss. Though we know very well, I already discussed Dr. This question will be discussed by Dr. Omer is here. Omer. Okay. If Dr. Omer is not here, Dr. Kutsia, Dr. Fatima.
Yes, ma'am.
Yeah, it's Dr. Fatima, right?
Dr. Kutsia.
Okay, Dr. Kutsia, read this question.
Okay. 20 days after MI, a patient develops sudden dyspnea on examination, tachycardia, desaturation 88% on room air, and hypotension and bilateral chest crackers. So the scenario shows that the patient had a history of MI. So right after MI, if a patient have chest crackers on auscultation, there must be edema. So the diagnosis is edema, pulmonary edema, and the first appropriate investigation we can do to rule out whether it is pulmonary edema or not, so we have to do chest X-ray. And the best investigation to identify the cause is, I think, echo.
Okay, excellent.
Yeah,
Doctor,
to
excellent.
see whether the ejection fraction and the other abnormalities.
Other abnormal. Excellent done. Dr. Kusa, excellent done. That is the way we have to make sure our presentation. This is the way after MI, pulmonary edema. Of course, this new saturation dropping. So we have to make sure is it chest X-ray by other respiratory cause. Then definitely we have to do the echocardiography to see is there any valvular abnormality present or not. Okay. So these are the way we have to make sure the presentation. And in heart failure patient, decrease mortality by AC inhibitor always. If AC, beta blocker, AC inhibitor both we can give, but beta blocker we can't give in asthma patients. So we have to make sure the surrounding information. In exam, dissecting aneurysm question, even recently few candidates, mashallah, all are passing, and recently exam candidates are giving the feedback regarding the dissecting aneurysm. They give nicely every point what marked here. Dissecting aneurysm or aortic dissection, my dear candidates, listen very carefully. After AMI, patient came to hospital. It could be the MI related or MI presentation or similar likely MI. So, but few strong point we have to exclude it. What are that? Unequal pulses in upper limb. This always they give this clue. My dear exam candidates, just remember recently few days before some exam candidates are my course. Unequal pulses in upper limb, aortic dissection. Marfan syndrome, very rarely they ask, even they ask, remember aortic dissection. Ehlers-Danlos and Marfan. They give this clue, pulse, unequal. Severe tearing chest pain that reduced to back. I mean heart is my fifth batch ongoing. Maximum candidates giving this feedback that this clue were there. Severe tearing chest pain reduced to back. What is your diagnosis along with the unequal pulse in upper limb? Patient presented with this instability. Sometimes they given, sometimes they didn't. So, how we will manage this case? Transesophageal echocardiography is the best or definitive for the esophageal. I will mark another point. Aortic dissection and patent foramen ovale. Chronic thromboembolism patient develops sudden DVT, sudden pulmonary embolism, but causology we don't know why patient is developing. There's no risk factor, but there's a patent foramen ovale. We have to make sure by going transesophageal echocardiography. My dear candidates, another point I always discuss, transthoracic echocardiography and transesophageal echography. You can make a note. Exam question. Transesophageal echocardiography exam question to see vegetation, left atrial thrombus, infective endocarditis develop aneurysm, develop vegetation. Two case, cause they ask in case of aortic dissection or patent foramen ovale. My dear candidates, make it note and remember. Transthoracic echocardiography is not exam question, but you have to know as you are a physician. Transthoracic echocardiography we have to do when? After AMI. To see the wall motion abnormality, to see the valvular heart disease, to see the left ventricular hypertrophy, to see the check the septal hypertrophy. My dear candidates, transthoracic echocardiography, transesophageal echocardiography, indication of choice, you have to make sure. So, aortic dissection, CT scan with contrast, another best one. So first, initially, if they ask, we can do transesophageal. Second, CT scan with contrast to see the dissection line, dissection parameter, dissection depth. Emergency setting, according to the option, I have to make sure my answer. Emergency doctor, unstable patient, will you do CT scan or ultrasound? This question will be answered by Dr. Dinakar.
Hi, ma'am.
Hi, ma'am. Hi, dear. You are
Yeah.
an emergency doctor.
Okay.
Patient come to your hospital with chest pain, tearing, radiating to the back, sweating, BP unstable,
Okay.
sweating, pulse is unequal, both arm. What you will do? What you
So,
will do? Initially, first of all, I didn't give you any option. Just tell me, ma'am, I will manage this case this way.
okay. So I would check with the CT option with CT scan.
Excellent. Why not? Why not ultrasound? Just tell me one point, ma'am. I will not favor ultrasound because this is the point.
No, because this patient is unstable.
Unstable. Excellent. If patient is stable, I can do ultrasound
Ultra.
to see the dissection. But patient unstable, I don't have any time to do ultrasound because it will not give any specific marker, right, Dr. Dinakar?
Yes, ma'am.
So I have to do CT scan. Excellent done. Thank you, Dr. Dinakar. So these
Thank
are
you.
the way we have to make sure as these are the question from the emergency. We have to make sure this way. This is the management. Another important management, just I am giving, I will go with those picture after my session. Just give me few. Aortic dissection management early later. So regarding the ascending descending type A, type B, remember my dear candidates, early they ask regarding sodium nitroprusside. I will give those images later after my session because this PDF is not for my prometric exam candidates, but few slides I'll post later. So remember, aortic dissection patient, initially you are emergency doctor. I have to make sure relief pain, sodium nitroprusside, beta blocker to decrease systolic blood pressure below 120. So exam question, either beta blocker or they give combination. My MOH candidates or other candidates remember very well, sodium nitroprusside and beta blocker. Just give me 1 minute, my dear candidates. Okay. So later, actually, always definitive management is a surgery, but they ask from the medication related. Ascending, always surgery, they will give type A value, or descending, always surgery if impending rupture. Medical treatment, beta blocker and calcium channel blocker. Okay. So these are the management point. And chest extra finding wide mediastinum. I just now remember one question Dr. Kutsia was asking regarding the question tension pneumothorax. As I remember, just give me 1 minute. I want to explain this question. Esophageal rupture was the answer. Dr. Kutsia is here, or who's asking in the group? Esophageal rupture was answer, and I was more tension pneumothorax. Anyone? Dr. Kutsia or Fatima, who was post this question?
Ma'am, I posed this question.
Okay, so doctor,
Yeah.
your question answer explanation was remember that widened mediastinum. There was clue. I was remembered this question they asked two way, and your question marking was esophageal rupture cause patient develop emphysema. They are asking. Can you repeat the question for me if you have?
Ma'am, let me check my gallery.
The question was what is the diagnosis, or if they ask what is the diagnosis, it will be the tension pneumothorax, and if they ask what is the cause for diagnosis, it will be the rupture esophagus. Cause
Yes, ma'am, I got the question. Can I repeat this question?
Yeah.
Okay, a patient present to ER after RTA or traffic accident with shortness of breath and examination, the tracheal shift to the left side and chest x-ray, the lungs are expanded and wide mediastinum. What's the diagnosis? The options were tension, pneumothorax, cardiac tamponade, pleural effusion, and rupture esophagus.
Okay, so just to give it, this is a very frequently asking question in the exam. If they ask after RTA and trachea shifted, it is tension pneumothorax. But this question tension pneumothorax will not be answered. Why? Because they mark another point, widening mediastinum. That means emphysema develops. So cause for the tension pneumothorax is esophageal rupture. Clear?
Okay.
Cause for the tension
Ma'am.
pneumothorax, if they didn't give this widened mediastinum in your clue, because recent exam candidates giving the same feedback, some got this same question, some got they didn't get any widened mediastinum. Widened mediastinum means emphysema develop, mediastinum widen. That's why answer will be the rupture esophagus. But if they didn't give, answer will be the tension pneumothorax. Okay.
Okay, ma'am.
Okay,
Thank you,
Dr.
ma'am. Got
Kuchi.
it.
That's why
Welcome.
just I remember widened mediastinum question, very important question regarding the aortic dissection. First of all, we have to do the transesophageal echocardiography, then CT scan initially or definitely you can say MRI and coronary injury to see the to assess if is any arterial block is present or not. So this question they ask this way. So ascending, descending regarding type A, type B. C. Type A, surgical management, but blood pressure should be controlled, beta blocker or sodium nitroprusside. Type B, conservative management. So type B question, if they ask, we have to make sure reduce blood pressure below 120. They give an IV labetalol if BP high, but sodium nitroprusside another option to management for the type B case. So type B case always conservative, type A case for the surgical management. LBB picture, my heart candidates, just shortly, actually I'm not so emphasized in this topic because LBB picture, if they ask ECG value, just remember William. What is William? We know very well William Marrow. William for the LBB. William is the CW pattern B1. M pattern BC. So William means we, W pattern B1, and M pattern BC, and marrow RBB. Marrow means what? M pattern B1 will be this one, and W pattern will be the BC. This is the William marrow for the RBB. Just see the ECG, and I already shared those PDF for the ECG. Just make sure those ECG pattern William marrow, William for the LBB and RBB for the marrow. LBB itself cause myocardial infarction, but my dear candidates, don't be mismatched or don't do wrong. LBB picture, but patient hypertensive long time hypertension, it could be due to the left ventricular hypertrophy. So don't make unsure by MI presentation. If patient present to your hospital MI with related chest pain, sweating, and patient LBB picture are there, okay, I have to make sure it's LBB, it's MI. But troponin I need whatever the troponin I, what is they are asking. So relation topic wise discussion we have to make sure, okay. So M pattern, and I already discussed regarding that. Rupture abdominal aortic aneurysm exam question they ask, rupture abdominal aortic aneurysm. This picture we know very well. Pain, hypertension, as it is already ruptured. If they didn't give any rupture, so it will not be hypotensive. There will be the pulsatile abdominal mass. Pulsatile abdominal mass will be there. Okay. So severe abdominal pain. Sudden come to your hospital, you are emergency doctor with lower back pain and flank pain, along with that hypertension. So we have to make sure surgical emergency. My dear candidates, make sure my MOS candidates and other recent exam consider initially what you will do if patient is stable. If patient is stable, we can do ultrasound, but if not stable, we have to do CT scan. Recent MOS candidates exam question. Same they ask rupture abdominal aortic aneurysm, patient is stable. Patient didn't develop hypertension. Patient is still stable. You can do ultrasound, but as emergency, if patient unstable, do CT scan. Chronic heart failure already I discussed. Restless syndrome already discussed. Hypokalemia picture shortly. My heart candidates, few exam candidates are there. UF will be there. They will give the ECG value. UF will be there. My heart candidates, make sure it's the hypokalemia. Is it diabetes related? Furosemide thiazide or not? Commonly congestive heart failure patient taking diabetes. They will make sure these are the ECG. Don't miss it. Because this is the UF. It is not T. You see, it's a P. It's a R. It's a Q. And it's S. It's a UF. I already discussed ECG value in my ECG session. So UF, just make sure for the hypokalemia and hyperkalemia emergency. I already discussed regarding the spiroelectron related force related hyperkalemia. So make sure it. Hyperkalemia, AC, causology, AC inhibitor, ARB, potassium sparing, diabetes, CKD related. My dear candidates, one question I want to discuss recently. This question will be discussed with me, but this is the exam question. Dr. Saba is here. So this is a very important question.
Yes, ma'am.
Okay, Dr. Saba, I want to discuss with you hyperkalemia because these are the exam question. 3 questions I'll discuss with you. First of all, a 45-year-old gentleman come to your hospital. Potassium 6 and ECG T wave present. They didn't say tall tented, they said ECG T wave present and potassium 6. Initially, what we will give? What you will give initially?
Ma'am, T wave
In ECG.
Okay, ma'am, it is indication of hyperkalemia, so we will give AC inhibitors.
Oh no, man. AC inhibitor itself cause hyperkalemia. I said it's a hyperkalemia. How you will manage means how you will prevent arrhythmia, right?
Ma'am, can I say?
Management, dear. I didn't
And
ask.
Dr. Kutsia?
Oh, you are Dr.
Mm,
Kutsia.
yeah.
Okay, Dr. Kutsia. Actually, when any other candidates discuss with me, just first tell me, ma'am, can I discuss? Then I will discuss. Because Dr. Saba, if she miss, it is not accepted. Then Dr. Kutsia, I will give
Okay,
you
ma'am.
place. Okay.
Sorry, ma'am.
Okay.
Okay, ma'am.
Okay. No, it's no, it's okay. Dr. Saba, it's the management. Potassium 6 T wave in the ECG. How you will manage initially? You have to know must.
Um, hyperkalemia.
Hyperkalemia management, tell me. Initially.
Sorry, ma'am.
Okay. I'm giving the option. It's not accepted. First of all, option A, initially. Initially, dextrose with insulin, calcium gluconate, magnesium sulfate, atropine.
Ma'am, calcium gluconate.
Initially, my dear candidates, actually, what I can say, with you, my Zoom session will be very less because your exam near. So, initially, calcium gluconate. Okay.
Okay, ma'am.
Second step, what? If it still persists, still potassium, you're checking 1 hourly, still 6. What you will do?
Then, ma'am, di-
Then
uh,
stepwise.
actually, ma'am, I am just
No,
joined your class, so
yeah,
I'm
okay. Hyperkalemia management, even if you don't join or lately, you have to know the very strongly. Dr. Pallavi, I'll give you place. I will discuss with Dr. Kutsia. Dr. Kutsia, discuss with me hyperkalemia management. Exam question.
Ma'am, first of all, we can give calcium gluconate. And then after that, insulin
With
with insulin.
dextrose. Second step. Okay. Dextrose
Okay.
with insulin, second step. My dear,
Hmm.
taking slot. My dear Dr. Saba, initially calcium gluconate, second step still not maintaining, give insulin with dextrose. Okay? My dear
okay,
Dr. Kusia. Dr. Kusia, still potassium 7, still not decrease. How you will manage?
Mm,
Same patient you are managing, you are emergency doctor, still 7, not decreasing. And patient goes towards the cardiac arrest. Before that, what you will do?
ma'am, sorry, I don't have any idea about this.
You have to do dialysis because this is the exam question.
Hmm.
It's a called resistant hyperkalemia, my dear Saba. For you, my strong advice: resistant hyperkalemia management is dialysis. You all
okay,
and
ma'am.
in exam question they given, you already given calcium gluconate, you already given this dextrose in insulin. How you will manage? And potassium is 7.5. You can't do early a patient in cardiac arrest. You have to make sure dialysis. It is another indication for dialysis. For my
Okay,
all exam candidates, and some exam candidates I can see in my platform, for them, strong advice, they ask tall tinted T wave in the ECG. Second, they ask how you will manage initially, and definitive. Definitive means what? Step by step. Initially calcium gluconate, then dextrose insulin, then nebulization you can give. That's it. And potassium also, potassium oxalate you can give, but still persist. Still persist means it's a resistant hyperkalemia. You have to make sure by doing dialysis. Clear, my dear candidates? All?
yes, ma'am.
Okay. Supraventricular tachycardia. Supraventricular tachycardia already I discussed regarding the ECG. And 6, 12, 12 value I already discussed the adenosine. If it is patient asthmatic, we have to give the verapamil. If patient unstable, we have to do the cardioversion. We have to make sure it. So these are the SVT picture. Torsus deep point is associated. I already discussed the ECG in my ECG class. So see the ECG value. If there's a torsus deep point is my MOH candidate, they asked regarding the management. We have to make sure IV magnesium sulfate initially Broad QRS complex prolonged QT. Prolonged QT itself cause toxicity point is. Prolonged QT when cause toxicity point is, I have to make sure IV magnesium sulfate. Key 29 will be discussed with me. Dr. Vizin is here. Dr. Vizin. Be active in Zoom. It will be good for your exam and good for your discussion. Key 29. Okay, Dr. Sajma. Dr. Fatima Pari.
Yes, ma'am.
Read question key 29.
K29. For patients who presents with a STEMI, give Mona, morphine, oxide, nitroglycerin, aspirin, and send immediately for PCI.
Dear candidates, just give me 1 second. I'm giving the clue. Dr. It's a Fatima, right? I'm
Yeah.
giving feedback. Right? Just to give me 1 minute. Dr. Fatima, I'm sorry for some incompetence. Just remember, read question for me again.
This is not question, ma'am. This is a
Yeah,
sentence.
a patient come to your hospital with ST elevated MI, because this question was discussed. That's why I just asking. ST elevated MI, and you already given Mona, okay?
Yes.
And you don't have cath lab for PCI. How you will
Okay.
manage? This question was discussed just for, I want to ensure that all my candidates know this. You are the doctor in surrounding, there is no cath lab for doing PCI. How you will manage? This question was discussed. That's why again I want to confirm it.
Heparin.
How, dear? Patient is still elevated MI, come to your hospital, you are given Mona. If it is within 4 hours, how will you manage? You have to know it. Okay, who know that within 4 hours?
Ma'am, can I tell this?
Ma'am,
It's a Nandini. Yeah, Dr. Nandini.
yeah, ma'am. We'll go for thrombolysis, ma'am.
Excellent. And what is your choice?
Yes, ma'am.
What is the choice of thrombolysis? Tell me the two names.
Can I say?
I asked,
I
tell
don't-
me the name.
For thrombolysis, thrombolysis is
Yeah, tell me. Just mute. Others can just mute.
ma'am,
Name?
we can thrombolize with rectiplase, tenectiplase,
Okay. And streptokinase,
yeah, ma'am.
right? And
And
okay, thank you.
streptokinase, yes, ma'am.
Yeah, excellent. So altiplase, tenectiplase, our choice of drug, excellent. I'll discuss. Every candidate was asking, mashallah, everyone excellent. So Dr. Fatima, same question, exam question, just mute the mic by other. Fatima, just remember, if question asked within 4 hours, but I discussed my first or second session, if there's no You are not a doctor of tertiary hospital. You have to make sure thrombolysis, because patient time will kill the patient cardiac muscle. You can't do it. You have to be safe. You have to do thrombolysis. Already given the monotherapy, morphine, oxygen, nitrogen already given. But time killing my muscle. So you have to do thrombolysis. Clear?
Yes, ma'am.
So okay, thank you. So another question, though this is a hard question, but I want to make sure we know very well. Dr. Pallavi raising hand. Dr. Pallavi is here.
Yes, ma'am.
Yeah, Dr. Pallavi, key 31 for you. Just make sure, yeah, you have knowledge.
MI acute chest pain radiating to jaw, shoulder, but without ST elevation on ECG. What to do next? Next we do cardiac enzyme, troponin. Troponin I.
Key
Yes, ma'am.
31, 6 weeks after MI,
Oh.
patient returns shortness of breath. This one. I said, what is the cause for the V1, V2 ST elevation? I asked this. Okay.
Sorry, ma'am.
Key 31 here. Key 31.
31. 6 weeks after MI, a patient returned with shortness of breath when walking long distance, and his ECG shows ST elevation in V1, V5 lead.
What is the cause?
Shortness of
cause?
breath. Walking elevation.
Yeah, walking long distance, still ST
Long
up.
distance.
So my doctor Pallavi just listen.
Ji.
6 weeks back, patient was treated with MI, but come to hospital again, chest pain, and you done ECG, and it's still persistent V1 to V6 delivery. Is it re-MI or again MI?
Again MI হতে মানে ম্যাম এটা তো anterior MI so স্টিলিভেশন again MI হতে পারে ম্যাম জি
Okay, okay.
I
Dr.
think
Badhan.
again.
Okay, okay. No issue. Because it's a difficult question. My MS candidates, no issue. We'll discuss because we have to keep clear our conception. Dr. Badhan, what is
Yes,
diagnosis?
ma'am. Ma'am, already patient
Shortness of breath due to
went.
left ventricular failure.
Ma'am, patient already went through MI 6 weeks back. And again, after ECG, we are showing that ST elevation in B1 to B5. I think it's a post-MI complication pericarditis.
Okay, okay, okay. V1 to V6. Okay. Dr. Reza. Okay, no
Yes.
issue. What is diagnosis? Your exam question.
Okay. ST elevation after MI, maybe it's a normal variation because of MI, because of the infarct muscle.
Okay, okay. So keep mute all candidates. I'm discussing. This is depth question, but this question they ask. Dr. Badhun nicely says it's a complication of IMI, but it's not pericarditis, because pericarditis picture will be the ST elevation in all leads. V1 to V6, every leads will be the ST elevation, but they said only V1 to V6. There, another important point, in exam they'll give 6 weeks before patient presented your hospital with anterior MI, and you done all. You done PCR, you done everything. But again, you are seeing there is a ST elevation in V1 to V6. What is the cause? Every day who are working cardiology, they are seeing this time kind of patient. What is the cause for this V1 to V6 ST elevation? This is the cause only for this artery developed aneurysm. That's why these are the persistent ST elevation due to the aneurysm. Dr. Pallavi, you tried your best regarding the shortness curve. It is not LVF cause. ST elevation V1 to V5 is not re-MI cause. Why? Already 6 weeks back, patient presented to your hospital with AMI and true AMI. Again, still persists. You've done everything. You've done stenting. You've done thrombolysis. So already this resolved. But again, ST elevation doesn't mean it's re-MI. It's the aneurysm. It's called left ventricular aneurysm. This clean-cut paid exam question, my DHA hat candidates. Just remember, they give another one information mistake. After MI means they said 6 weeks after anterior MI. So same lead again, ST persistently elevate. That means it's a aneurysm developed there.
Aneurysm. Yes, ma'am.
Okay, clear?
Yes, ma'am.
All clear?
Yes,
Aneurysm.
ma'am.
Okay. Thank you, my dear candidate. So remember, left ventricular aneurysm persistent ST elevation, which goes towards after post-MI, it goes towards the left ventricular aneurysm. Clean cut scenery for exam, though it's a depth, but I have to make sure if question hard, we have to know every point towards. It will be nice if when I discuss mute the mic, when I said the name of the candidates to discuss, unmute only these candidates. Hypertension management is the core of the cardiology, core. We have to make sure the management. Myself, I don't bother stage 1, stage 2, stage 3 because exam they ask, I'll discuss few questions after my session. Exam question they ask, what are the management, how you will manage, these are the age. So shortly I'm to discuss stage 1 means it will be the 140 by 90, stage 2 means 160 by 100 and stage 3 means 180 by 110. So you can make a note shortly 140 by 90. And every candidate must make a more note. I will give this PDF all, but make sure what I had emphasized, those topics you have to must know. So 140 by 90 is, or so stage 1, 160 by 100 is stage 2, and stage 3 is 180 by 110. Management. Lifestyle modification if patient said obese, smoker, alcoholic. So initially you have to tell lifestyle modification. Stage 1 hypertension, lifestyle modification, and review follow-up. Keep follow-up. Hypertension urgency, hypertension emergency. What is the definition? Hypertension urgency means patient come to hospital with headache, with restless BP 110, 180 by 110, BP 180 by 110, but patient presentation headache, blurred vision. Urgency still, organ not damaged. If any organ damage, patient develop failure, heart failure, hypertensive, left ventricular failure, hypertensive, renal impairment, it's a hypertensive emergency. This picture my MOH had and DH and other candidates, so the candidate just remember, if end organ damage, it's the urgency, not it's emergency. If it's not damaged, it's the urgency. Just one point. They said renal impairment means creatine 3, so it's the hypertensive emergency. Worldwide guideline, if patient come to your hospital 50 years of age, this question will be discussed with me, Dr. Solomon is here, Dr. Sherin, who is there? Solomon, Sherin, Dr. Dr. Donilda, anyone?
Yes, ma'am.
Yeah.
Yes, yes, ma'am.
50-year-old gentleman come to your hospital with BP 160 by 100 and complaining of, ma'am, I have a headache.
Yeah, yes, ma'am.
And you keep this patient on follow-up. Still patient last BP 150 by 100.
Yeah.
How you will manage this case? Age 50.
ACE inhibitors. Start with ACE inhibitors.
Okay, excellent.
Lisinopril, enalapril, captopril.
Okay, excellent,
And
excellent.
yeah. And
If anywhere patient diabetic, whose drug will be your choice?
patient diabetic along with hypertension.
Yeah.
Along with. Okay.
Same.
Less than
There's
50. Same patient. Yeah.
same.
Okay.
Same
Um,
patient.
Any group of metformin?
No,
Metformin?
I mean same patient. Patient diabetic. Will you change your medication as inhibitor or you will keep this medication? It is my question to you.
Okay.
Patient diabetic
No,
means we have to make sure SC inhibitor first.
Yeah, ACE inhibitors only.
Because it is renoprotective.
Yes.
If Dr. Donilda said patient is 60, diabetic, what medication you will start? 60, diabetic. These are the exam question I'm discussing.
60. Verapamil, diltiazem.
I said 60, but you have to say, ma'am, it's the SC inhibitor or ARB. It doesn't mean verapamil. Because why? Patient diabetic. Patient diabetic, we have to make sure renoprotection first. I can't give CCB. I can't give CCB. This is the twisting question. My every exam candidate, if patient is 60, 65, now recently diagnosed hypertension, you have to make sure AC inhibitor, not CCB. Clear?
Okay, ma'am.
Okay. Thank you.
Yeah.
Dr. Donita,
Thank you.
thank you.
Thank you.
I am seeing my platform many candidates, but be active and try to discuss with me. It will be best. So below 55, AC inhibitor, more than 55, CCB. If patient diabetic, we have to make sure AC inhibitor. Okay. AC inhibitor enalapril we have to choose. Then CCB we have to choose amlodipine. But in case of patient anyway, whatever the age they give, if diabetic, we have to make sure AC inhibitor first to as a renal protection. We have to make sure another thing that if patient come to me hospital, if patient come to my hospital, potassium below 4.5 with diabetes therapy, patient on heart failure and hypertensive, we have to add potassium spironolactone, potassium sparing drug. Okay. Just keep on mind, diabetic hypertensive patient gold standard question for the exam. Diabetic hypertensive with diabetic, without diabetic, with diabetic, AC inhibitor, without diabetic, according to the age, we have to make sure. We have to check EGFR level, any kind of CKD patient, because if EGFR below 30, we can't give AC inhibitor. Though AC inhibitor role as renal protection against retinopathy, against it can act as glucose metabolism. So if we keep monitor EGFR level, it's stable, we have to continue. But if it is below 30, we have to stop AC inhibitor. I want to discuss a question with Dr. Rekha is here. Okay. Dr. Hira.
Yes, ma'am.
Yeah. Dr. Hira. My question I already discussed, but just for getting feedback.
Yeah.
A 55-year-old gentleman come to your hospital with BP 130/80 and patient on enalapril. Patient on enalapril, and you say you checked his EGFR which showed 28 EGFR value. How you will manage this antihypertensive drug? Will you continue or will change? And what drug you will suggest?
Ma'am, if it's GFR is less than 30, it's 58, it's greater than 30, we can continue the drug. If it's less than 30, we have to stop the drug.
EGFR 28, what you will do right now?
28
Patient
or
58, 28.
Yeah, ma'am.
What you will do?
If it's its GFR is less than 30. So we have to stop the drug.
And what you will give this patient 55. Is this exam question 55, AGFR 28, what you will give? You have to stop and start what?
Calcium channel blockers, madam.
Calcium channel blocker. Verapamil, diltiazem, there is the option. My exam candidates, remember, we have to change and we have to, there is the option stop and start diltiazem. Stop and start a continue management. Same, like that way. So stop and change to diltiazem or verapamil, what they give, CCB. Clear?
Thank you, ma'am.
Yeah. Cardiac arrest algorithm already I discussed my second session, so there is nothing to know. This key 44 will be discussed. Dr. Ikra is here.
Yes, ma'am.
Read the question and tell me the diagnosis.
An elderly male presents with palpitations and shortness of breath on exertion. The ECG is as follow. What is the diagnosis?
What is the diagnosis?
Ma'am, atrial fibrillation.
Excellent. Why? What you are saying? There is a what?
P wave is absent and irregular.
Excellent. 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 This picture same as exam question. It's atrial fibrillation. Right?
Yes, ma'am.
Okay, thank you. So how you will manage the rate rhythm? Tell me, ma'am, I want to manage it this way. There's echo. You can mute the echo and you can talk with me.
I will give beta blocker.
For the rate?
Yes, ma'am.
For the rate. If I said rate 130, you can give beta blocker. If patient on heart failure, how you will manage the rate? I was discussed.
If the
with
rate...
same patient but patient heart failure, what drug you will give for rate control?
Ma'am, beta blocker.
Dear, I said heart failure.
Then digoxin.
Digoxin, okay? You have to add digoxin. Okay, thank you. So, thank you, Dr. Ikra. Though you were confused, for heart failure, rate control by digoxin if there is AF present, okay? If there's no heart failure, there's a beta blocker. So presentation here, thank you, doctor. So atrial fibrillation, palpitation, tachycardia, dyspnea, here the presentation, there's a P wave absent, irregular rate. So it's the atrial fibrillation, you have to make sure it, and if patient asthmatic, you have to give the calcium channel blocker. Supraventricular tachycardia, already I discussed regarding the ventricular tachycardia, all goes towards that, and very important exam question. After AMI, commonly patient develop mitral regurgitation due to papillary muscle rupture. So it's a common complication, and we will find out pansystolic murmur. Murmur related question I'll discuss today. A few candidates are very confused regarding the murmur, systolic, diastolic. I'll make sure it, and I'll shortize these types of questions. So mitral regurgitation after AMI, patient present to your hospital, and you will find out there's a pansystolic murmur and the patient hypotensive tachycardia, pulmonary edema develop, and we have to make sure the echocardiography pictures will be given there how you will manage vasodilator along with diuretics cause patient develop pulmonary edema. That's why. So we have to make sure a patient develop pansystolic murmur with pulmonary edema after AMI, the patient not stable. We have to vasodilate the arteries and we have to make sure the furosemide. VT related question I was discussed my second session, that stable synchronous shock, non-synchronous shock, amiodarone, cardioversion. Two question we have to make sure. Broad complex tachycardia, actually generally in cardiology we have to do cardiovert. This is shock, but if unstable. But if stable, we can give amiodarone. If unstable, if we have to give cardioversion. Like that way, we have to know the steps. Unsynchronous shock always in unstable patient, synchronous shock always in stable patient. This is the tall T where you see there's a hyperkalemia management I already discussed. So see Dr. Sabah for you, IV calcium gluconate for the initially and manage insulin with dextrose. Second steps. So see, these are the pictures. Just remember strongly below 55 AC inhibitor, more than 55 ccV. If a patient diabetic, AC inhibitor or ARB. The murmur related question, I already post a chart in my group, diastolic systolic. If you do a trips, what is that? Just give me 1 minute. Because we have to make sure the murmur related question, easy question, my DHA candidates. These are the heart, just patient candidates are waiting. When I'll share the whiteboard, candidates will go wait. That's the fact. So we have to make sure it. So right side and left side in our body, remember. Right and left, easy to remember. This is the fifth intercostal space. There is the apex bit, fifth intercostal space. This is the fourth intercostal space, and this is the second intercostal space. So my body, this is the pericardium. If you mark 1, 2, 3 from the clavicle, it is the fifth intercostal space. If you mark 1, 2, 3, this is the fourth intercostal space. This is the second intercostal space, and in right side, this is the second intercostal space. So fifth intercostal space, mitral valve. Left second, pulmonary area. Right second, aortic area. And fourth lateral side, it's the tricuspid area. So fifth mitral area, fourth tricuspid area, left second pulmonary area, right second aortic area. Then murmur. M cause MS, MR both. MR pansystolic. MR. MS diastolic. So MR systolic, Mrs. If you remember, MRS systolic, MD, M is a diastolic, MDS. So M, fifth intercostal space, M is diastolic, MR systolic. Now left lateral fourth intercostal space. Left fourth intercostal space is a tricuspid area. I am hearing TR. Tricuspid regurgitation. It's a pansystolic regurgitation. So MR, TR, pansystolic, TS. Never exam question, MR, MS. Make sure TS, diastolic murmur. Now I am keeping my stethoscope in second intercostal space of the left border. So left border is a pulmonary area, second costal space. So I am hearing PS. What is that? I am hearing systolic murmur. Shush, shush. There's a hollow or there's an ejection systolic murmur. So it's a PS. I'll point out later. PS, and I'm hearing PR. PR is a diastolic murmur. In left second intercostal space, I can hear second harsh sound splitting in nature. It means it is ASD. I can hear fourth intercostal space ejection systolic murmur. It could be ventricular septal defect. We have to make sure, according to my scenario, is that VSD or it is TR. TR never recall. PR never recall, but VSD, MR is my recall. So we have to emphasize on that point. Pansystolic murmur, fourth intercostal space, ejection systolic murmur, whatever. I forget the name of the candidates. She was asking regarding the systolic. Make sure elderly patient, older age patient, ejection systolic murmur always is aortic stenosis. My DHA candidates, you have to do AVR replacement, aortic valve replacement if valve area below 1 centimeter. If elderly patient asymptomatic but they say severe, this word severe is, you have to make sure valve replacement cause this AS patient presented your hospital with complications, syncope, chest pain, failure. So you can't wait. You have to do valve replacement. So what I said, exam question AVR replacement when, mitral valve replacement when, percutaneous coronary commissurotomy when. These are the exam question. We have to know if elderly patient, ejection systolic murmur, asymptomatic, but they said one was severe. They didn't give any valve area value. You have to make sure AVR. But they said, see, aortic stenosis, patient asymptomatic, how you will manage? You can't keep observation. Because they didn't give valve area, they didn't say severe. Now, mitral area question, my dear candidates. Mitral area question, MVR and PTMC, percutaneous coronary commissurotomy, mitral commissurotomy. Rheumatic heart valve disease patient always stenost, MS called stenost commonly. If patient symptomatic, we can do ballooning or commissurotomy within 1 to 2, valve area within 1.5 or 2, but patient symptomatic, we can do ballooning or commissurotomy. We done commissurotomy, actually we practice, younger age patient we practice commissurotomy, but if below 1 centimeter, commissurotomy done 2 times before, now patient breathless, systemic hypertension, pulmonary hypertension develop, you have to make sure MVR. So these are the exam recall what I said. AVR, asymptomatic, not severe, we can do observation, but MVR, when we are doing commissurotomy first, in case of valve area 1.5 or 2, but if below 1, patient breathless, pulmonary hypertension developed due to mitral stenosis, we have to make sure MVR. So, valvular heart disease, murmur related question, VSD, ASD, always goes towards the murmur related question. This fixed splitting heart sound to the ASD. VSD could be the complication after MI, common complication MR, how we have to make sure regarding the presentation, and valvular heart disease along with the mitral and aortic valve area. We have to keep decision. I hope all clear. Or anyone can ask me any question if anyone face any difficulty. So already this area, pancreatic area already I discussed. Just remember this PDF already given the access. And this scenario you see MI and orthopnea, but pancreatic murmur is the MR, pancreatic murmur, and we have to do the echocardiography. MS related criteria already I discussed when we have to do the valvular PTMC, when we have to do the MVR already they discussed here. DCM, very important exam question. Postpartum cardiomyopathy in, I don't know why they like very much. My DHA candidates and the other candidates, this DCM, they like very much postpartum cardiomyopathy actually. Frequent recall. So DCM means dilated cardiomyopathy, left ventricle dysfunction. It could be any valvular cardiomyopathy or it could be any valvular dysfunction or any left ventricular function not working. Patient alcoholic. So alcoholic cardiomyopathy. Patient delivered a baby 1 month back. Now postpartum cardiomyopathy. These are the scenario they will give the clue. Patient develop MI 6 months back. Now develop shortness of breath, and you see in the echocardiography ejection fraction 30%. So it's the IDCM, ischemic dilated cardiomyopathy. IDCM. Dilated cardiomyopathy could be postpartum, could be alcoholic due to the, or it could be any previous MI infective related, and hyperthyroidism. Dr. Reza's question, gallop rhythm, palpitation, how, why I will check this. You have to make sure, is it hyperthyroidism related or no? I already discussed this question in my first. So Dr. Reza, you have to make sure TSH value, is it hyperdynamic circulation, is it arrhythmia ongoing due to the hypothyroid or hyperthyroid status? You have to make sure. So infective cause, endocrine related cause, neurovascular related cause, Duchenne muscular dystrophy, all are goes towards, all can be the cause for the dilated cardiomyopathy. My dear candidates, just remember the scenario, what they are saying, what goes towards the point for my diagnosis. Is that alcoholic? Is that postpartum? Is that TSS related? Gallop rhythm, hypertension due to the what? Due to the frequent valvular pumping. That's why patient tachycardia, that's why patient BP is high rising. That's it. Due to thyrotoxicosis or hypothyroidism, we have to make sure TSS value. Kwashiorkor pellagra, this question, very common question. Kwashiorkor topics will be discussed later. This is from the vascular disease. I'll discuss later. Inherited cardiomyopathy, DCM, autosomal dominant. It's another component. It's HOCM. HOCM patient. HOCM related question. Just make sure. Just I'll discuss HOCM later. Congenital heart disease, just remember cyanotic congenital heart disease, acyanotic congenital heart disease, this is the component. Cyanotic truncus arteriosus transport, this component you have to make sure you know very well. So cyanotic truncus arteriosus, transposition of great vessels, tricuspid atresia, tetalocophalus. So acyanotic ASD, VSD, PD, and coarctation of after DHA candidates. So remember very well, and so the and all exam candidates remember cyanotic acyanotic variation, and important to remember acyanotic cause and cyanotic cause. So pancreatic murmur they given a manomix. Patent ductal arteriosus they ask continuous machinery murmur. What is the diagnosis? Continuous machinery murmur is a PDA, it's the insanity. There is a defect on the congestion of pulmonary and descending aorta. You see, pulmonary and descending aorta, there is a connection, it's the patent ductus arteriosus. Continuous machinery murmur, exam question. And collapsing pulse, large volume, bounding type. Okay, we have to make sure the echocardiography. Another exam candidates, another question. Prostaglandin and indomethacin. When we will choose prostaglandin, cause what? Cause closing the connection. So if we need to open the duct, we have to inhibit this prostaglandin synthesis by NSAIDs. If we keep open the duct, we have to give prostaglandin. Two questions there. How, which medication will close the duct? Indomethacin, NSAIDs. Which medication will close the duct? So close the duct by indomethacin and keep the duct open, prostaglandin. Tetalogia follows the component of the VSD, right ventricular hypertrophy, right ventricular outflow obstruction, overriding aorta. This is the presentation. Pictures will be the cyanosis, that's ejection systolic murmur, okay? Ventricular fibrillation management regarding the ALS protocol, I already discussed. VSD, just remember, this is the pansystolic murmur. There's a left sternal body, I already discussed. Complication, chest X-ray initially, already all discussed. This murmur also. So 2 points I want to discuss, and I'll discuss few questions also. HCM and DPT related question. HOCM, my dear candidates, actually they give a family, it's autosomal dominant, and there will be the family history of sudden cardiac arrest, and there will be double apical impulse, impulpation, and there will be the auscultation, there is a pansystolic murmur. They ask how you will manage echocardiography, there will be the septal hypertrophy, that's it, no need to remember all things, and management will be, I'll give A, B, C, D, E. What is A, B, C, D? A, B, C, D, E means amiodarone, beta blocker, and ICD, ICD replacement. I can't give night therapy. What is night? Night therapy means I can't give nitrate, I can't give inotrope, I can't give atropine. So this ABCDE HOCM management, just remember we have to give amiodarone, beta blocker, and definitive management is ICD. They'll give patient come to hospital with chest pain, racing of the heart, history of sudden or a player or football player come to hospital only age 25 with palpitation, family history of sudden cardiac death. How will manage? So give beta blocker or amiodarone. Definitive always ICD, because there will be the VT-VF, we have to confirm this ICD. DVT management, my dear, can DVT and pulmonary embolism, just remember, a patient come to my hospital, painful leg swelling, venous duplex initially. So we have to start anticoagulation. I forget the candidates that remember long-term anticoagulation like that, they ask me. Maybe in my group or warfarin related question. When frequent DVT, just keep one word: provoked, unprovoked. Provoked means what? Provoked means we know the cause. Either patient SLE patient or antiphospholipid patient has cause for the provoking factor, provoked. We have to continue anticoagulant 3 months, provoking factor 3 months. Unprovoking factor, we don't know what is the cause for frequent DVT. We don't know. Coming my hospital pulmonary embolism, coming in my hospital DVT, but what is the cause? long-term or 6-month therapy. So see the option what they mark. If they say 6 month, one option, mark it. If they say no, long-term, mark it. So unprovoked, always we don't know the cause, it's the long-term or 6-month therapy. Okay, these are the exam question. Pulmonary embolism related question, already I discussed. The CTP we have to do, massive pulmonary embolism, submassive, and D-dimer it will be raised, and we have to do VQ scan in case of pregnancy, already I discussed. CT angiography more specific. Okay, VQ mismatch is the diagnostic in case of pregnancy. That's it. You have to remember. Initially, you have to make sure the heparin, and then, if needed, warfarin or long-term anticoagulation. S1 Q3 T3 pattern exam question. They ask, even if you don't know the ECG, you can't read. Just remember S1 Q3 T3 option. That's it. Acute pulmonary embolus. So C S1 Q3. So C. These are the S1. These are the S1. S Q3. This is the Q. Q. T3. In 3 there is a T. So S1 Q3 T3. This is the pulmonary embolism. If anyone can't remember this one, no issue. Just remember this volume. This they asked directly what is the picture. So if any contraindicated for the anticoagulation, we have to make sure IVC filter. Okay. Initially, massive pulmonary embolism patient unstable, we have to do thrombolysis, embolectomy. Submassive anticoagulation or long-term anticoagulation, we have to make sure by provoked, unprovoked factor. So see, if recurrent or lifelong, my dear exam candidates are who was asking in my group, posting the question, if frequent, long-term or 1 year. If post-operative, 6 weeks. If pre-provoked, unprovoked, remember provoked 3 months, unprovoked 6 months, but if frequent, lifelong. If recurrent. If contraindication for anticoagulation, patient recent stroke, patient recent MI, we have to do IVC infiltration. So my cardiology, alhamdulillah, I am ended every topics, higher topics I discussed regarding the exam, hypertension, murmur, MI, ECG related question. I already posted my PDF in my Access. Just keep on eye, or even if you need, you can hear my session frequently, because these are the topics what they ask in the exam. So shortly, I want to discuss few questions one by one. Two to three questions I'll discuss just it. So this question, just read, and a question will be answered me, Dr. Actually, I always announce the exam candidate's name. Best to unmute the mic and discuss with me. Dr. Vizin is here, Dr. Saba. If not there, I'll ask another candidates. Dr. Saba, Dr. Vizin, Dr. Afrin Keka. Try
Yes,
to
madam.
participate. Yeah,
Dr.
try to
Afrin
participate.
Keka.
Even, yeah, okay. Try to participate even if you do wrong, no issue. Because we in this platform we'll do more wrong. Then we have to clear our conception. So read the question, dear. Okay.
A 55-year-old female presents to the emergency department with 8-hour history of heart palpitation. She has a heart rate of 200 beats per minute, and ECG shows regular QRS complex of 0.08 seconds. She has not had any chest pain or episodes of syncope, and has no signs of heart failure. Her blood pressure is 130/90 millimeter mercury. Her oxygen saturation are 97% 1 year. What should you do first?
So what is diagnosis? Sir, Dr. K. Kasi, QRS complex 0.08 means what? And what is the diagnosis? Say, ma'am, it is the diagnosis. Say, what is the diagnosis? Before management. What you are thinking? Sinus tachycardia, QRS 0.08 and rate is high. 200
VT?
beat rate.
VT?
If VT, QRS complex would be more than, it's a narrow or wide?
VT white. White.
Wide. If VT, is it VT? 0.0. If I say, Dr. Keka, my one small square is 0.02, one small square. So if you do calculate, so 4 small square means 0.08. So it is more than 3. I said if it's more than 3 small square, it will be the VT. I said if it is below 3 small square, it's the SVT. I said it, right?
Yes.
So what the small square it is? Is it?
SVT.
No. I said 0.08 here. So it's a more than 3 small square, right? Or it's a more than is 0.02 and it's a, if you mark it 4, so it's a 0.08, right? So is it, I said, is it below 3 or more than 3?
More than 3.
Okay. Somewhere they say 0.04 normal, 0.04. So if I calculate this way, it will be the below 2 small square, right? If I say below 3 small square, 0.04, it will be the below 3, right?
Yes.
So they will give this value. Here they didn't give the value, but in exam, small square value 0.04. So is it VT or SVT? .08 here.
SVT.
Okay. So initially how will manage?
Adenosine.
Initially.
Initially,
Dear.
carotid sinus masses.
Yeah. Carotid sinus masses is the answer initially, right? Right?
Yes.
Clear. So my dear exam candidates, just remember 0.08. Yesterday my session I was say 0.0 to 1 small square. Somewhere they must 0.04 is a normal 1 small square. So remember 0.04, the maximum time they recall the given 0.04 normal 1 small square. So if it is 0.04, I said more than 3 small square is VT. So if I calculate it, it will be 0.12. So where only 0.08, it means it's only 2 small square below 3 small square. So it means it's the SVT. So management will be the what, Dr. Keka?
Carotid sinus masses.
Then the rules of what?
Then
the management.
Adenosine.
Yeah, tell me, adenosine value. What will be the stages? 6, 12, 12. After I will give IV 6, then 12, then 12, right? 6,
Yes.
12, 12. Yeah. So see here, they said we have to make sure 6, then 12, then 12. Okay? Clear?
Yes, madam.
Yeah, thank you, Dr. Keka. You done well. This TAGFA score, I'll asking Dr. Aisha Naim is here. Aisha Naim. Dr. Priscilla.
Yes, okay. Priscilla.
Yeah. TAGFA
70.
score.
Yeah.
Yeah.
Okay. A 71-year-old man who is known to have atrial fibrillation comes for review. He had a transient ischemic attack 2 weeks ago and takes bendroflumetazide for hypertension, but is otherwise well. Latest blood pressure is 124/76. You are discussing management option to try and reduce his future risk of having stroke. What is his chart was score? So he's 71 years old. So score is 1. TIA score is 1. Hypertension score is 1. He's a male. No score. So 3.
Your score transient ischemic at a previous history of the stroke is a CVD. It's a CVD. So CVD score is what? CVD score is
2.
2. Yeah.
Oh, okay.
Okay.
2. Okay. Right. All right.
4. Dr. Reza is here.
Yes.
Discuss this question. Read.
Okay. A 28-year-old man with hypertrophic obstructive cardiomyopathy is investigated for palpitations, a 24-hour EKG reveal runs of non-sustained ventricular tachycardia. What is the most appropriate management? VT and non-sustained VT. The first initial treatment is amiodarone.
Most appropriate, they ask.
Most appropriate is stable hypertrophy, but yes, it is stable. I think the most must be there are two options: amiodarone for a stable patient and cardioversion for unstable patient. There isn't any.
Dr. Reza, I discussed ABCDE HOCM patient. ABCD amidon beta blocker initially, but best definitive.
Definitive is cardioversion.
What is answer?
The answer is implantable cardio.
In ICD, I said ABCD implantable cardioverter definitive always.
Yes.
Not cardioversion. Because VT sometimes paroxysmal VT.
Yes, the most appropriate.
VT. Most appropriate temporary VT, paroxysmal VT, we have to make sure ICD.
Yes.
Is that the answer of your question? Okay, thank you, Dr. Reza. Another candidate from Dr. And he is still not discussing Dr. Rekha, Dr. Aisha Naim, Dr. Fatima Pari, Hira, Ifada. Ifada is here.
Yes, ma'am.
Yeah, Ifada. Just keep with me. I'm discussing with you, doctor. Just keep with me.
Okay.
Start.
Okay. 51 years old man presents 4 weeks after being discharged from the hospital. He had been admitted with a chest pain and thrombolyzed for a myocardial infarct. This morning, he developed marked tongue and facial swelling. Which one of the following drug is most likely to be responsible? Ramipril, ACE inhibitor.
Answer is what?
Ramipril.
ACE inhibitor. So what is the diagnosis? What is the diagnosis? It's a
angioedema.
It's angioedema.
Angioedema.
Okay, thank you. It's the angio. It's inhibitor related angioedema. Okay.
Okay.
Okay, thank you. Another question will start with me, Dr. Sashma.
Yes, ma'am.
Dr. Sashma. Excellent, excellent. Okay, stay with me. Read, Dr. Sashma. This one. Very important exam question.
76-year-old man is reviewed. He was recently admitted after being found to be in atrial fibrillation. This was his second episode of atrial fibrillation. He also takes ramipril for hypertension, but has no other history of NOS. During admission, he was warfarinized and discharged with planned follow-up in the cardiology clinic. However, on review today, he is found to be in sinus rhythm. What should happen regarding anticoagulation?
So, Dr. Sashma, after reading this scenario, what you have to do right now?
Will continue warfarin for 6 months.
No, I asked that, sir. You see, atrial fibrillation and also again is atrial fibrillation. So 2 times, right? Already in patient on warfarinized. And you
Okay.
have to prevent thrombosis. You have to, will you, why 6 months? Do you know the cause? You don't know, right? If I say
Yes,
it's frequent, will it be lifelong or 6 months? I said
if it is
frequently.
recurrent, then we'll continue it for
Yeah,
lifelong
because it is
warfarin.
recurrent. Because they say, you see,
Yes.
recently admitted. So means patient already on warfarin, but recently on frequently, second time, third time patient is admitting. There's
Yes.
no history of no. There's nothing. So unprovoked, you nicely tell me, ma'am, it's 6 months. Yes, it's 6 months, but frequently
Lifelong warfarin.
lifelong. Thank you. Remember this way. This is the exam question. Last question will be discussed with me. Thank you, Dr. Sasma. Dr.
Thank you,
Rekha.
ma'am.
Yeah, Dr. Rekha. Sharon, John, anyone? Vizin, one. Dr. Sharon, John, Rekha, Vizin, who are there? Dr. Priya. Maha Umar. Okay. Dr. Reha is not here. Maha. So Maha Umar. Yeah. So it will be little bit difficult, but try to answer.
Yes, madam.
Keep
Can
with me. Yeah. I'm giving there. Just give me 1 minute. Yeah, start. I already discussed this question. Tell me your diagnosis and management. Last question today.
A 55-year-old man is admitted to emergency department with tearing chest pain radiating through to his back. Examination reveals a pulse of 96 per minute, regular blood pressure 130/85, and oxygen saturation 97% anemia. A chest X-ray showed mediastinal widening. A CT showed dissection of ascending aorta. What is the most suitable initial investigation? Diagnosis is aortic dissection because chest pain, tearing chest pain radiating through his back. And initial management, IV sodium nitroprusside. First of all, we have to relieve
Decrease
the
the
patient mona mostly, relieve the pain, and
pain,
then we
then
definitely move, and
decrease the
then
blood
IV
pressure.
sodium nitroprusside.
Yeah, excellent,
Yes, madam.
excellent. Yeah. So it's a They said IV
IV sodium
labetalol,
nitroglycerin.
yeah, it's no reason they're ascending aorta, IV labetalol they said, and IV sodium nitroprusside if it is BP higher, more than higher. But yes, absolutely it's IV labetalol first, okay, doctor. First of all, we have to control the BP. In this, our BP target is below 120, below 120, okay. So I have to mark first labetalol, then sodium nitroprusside.
Okay, ma'am. Okay. Okay, ma'am.
So first of all, descending aorta labetalol, if ascending, first labetalol, then surgery. And if it is not controlling by labetalol, we have to make sodium nitroprusside second step.
Sodium
Okay.
nitroglycerin. Okay, ma'am. Okay.
Okay. So hoping my cardiology session ended my third session today and all clear, even till my 45-day, even anyone feel any confusion, it will make confused, no issue. It is make question to me, ask me, no issue. But make sure important emphasize those point murmur, MI related complication, Dressler pericarditis, infective endocarditis management. I'll post those PDF, images later after my mock. Then I'll take 15 question mock after my this recall practice. Tomorrow I'll post those question at evening. Make sure be active, my candidates. You have to ace the exam in first attempt. So it is my wish from my course. Inshallah, all are passing from my course. Till now, no failing rate. Alhamdulillah for that. So I'm ending my session. Allah Hafiz for all. Thank you, my dear candidates. Assalamu alaikum.
Bless you. Thank you, ma'am.
Thank you, dear.
Assalamu alaikum.
Thank you, ma'am.
Thank you, ma'am.